This is a patient who came to the hospital with a problem of significant lesion in the esophagus. It was a while ago. It was back in May of this year. And the lesion was circumferential. So it was a squamous cancer, and the pathology showed SM3, well differentiated, no lymphovascular invasion, complete endoscopic resection with histologically free margins. During the procedure, we placed a stent for preventing a stricture, but the patient couldn't tolerate it. She declined surgery and radiochemotherapy because that was indicated from the mock discussion based on the pathology. And since then, she has had dysphagia. It's been pretty well treated, I would say. The last dilation she had was, well, they were a month apart in September and October. And she's been tolerating diet pretty well. But she called us recently to say that things were maybe going a little bit worse again. So this is an endoscopic only approach out of necessity because our fluoroscopy feed to the seminar room is broken. So this will be a nice case. Tamaj is here with me, all the way from Hungary, just for your entertainment pleasure. Take it away.
Yep. So we just introduced the scope. I already introduced also some sematicon to make it easier, the assessment. And yeah, the previous stricture was described where just at the top of the resection bed, which is 32, we are approaching that area. Already we have something here. All the biopsies previously showed 32 and distally just granulation tissue. And yeah, now we are at 30 and yeah, 32 where the previous resection bed was. The maximum dilatation was until 12 millimeters. We see at this region a little more than a pinpoint stenosis, but yeah, which is ulcerated.
Okay, so I'm not sure I agree with most of what you said about stricture, so let's come back and discuss that, but just come back a minute. So you said, oh, here's actually something. So what were you talking about? What do you think that is? There's something up at the 1 o'clock at the moment. Imagine reaching for the MBI, I think. Getting there. There you go. What is that? We won't spend too long on it. We'll come back to it later. I think it's nothing to worry about. I certainly don't think that that is the margin positivity of previous.
I don't think so.
Okay.
I can't.
Let's come back into the proximal esophagus just to check. Come back. Yeah. Come back more. Looking for inlet patches. If we come back more. I don't see one, right? Okay, so what is happening in this esophagus? What do you see?
So from here, I think, so this patient was stented. So probably this was the previous
okay. What are these?
Of the stenting?
That is the stent fix line. Yeah. What is all this exudate around? There's lots of food sticking. Maybe there's a bit of inflammation going on. Tell the people watching, I know that you know, these appearances are related to the reason she got a squamous cell carcinoma. So what do you see here?
Chronic inflammation.
Yes, we see chronic esophageal inflammation.
With some scarring. Yeah.
With some scarring, but also here associated with exudates, I would say, on the surface. I don't think this is necessarily all food. And then if we just go down a bit and put on narrowband imaging again, please. So look at the background. You have this chronic change, which is kind of, there's surface mark epithelial change. Some of it may be food above the stenosis, but some of it's also inflammation. Why are you not sure that
it's maybe not necessary? What would be the right word?
Don't tell me in Hungarian. Yeah. I mean, I'm getting quite good at it.
Yeah.
You can try me.
Yeah, okay, let's stay with necessary, yeah.
Okay. So, but let's unpack that, because I think it's a really important question. It's what everybody said at the start. Everybody said to me, how do we know when to stop, right? Because this is a great example.
So necessary is actually the word that I'm. No.
Well, necessary is a word.
Dysphagia. We want to relieve dysphagia.
Right. But what about safe? Is it safe? That's another good word, right? Safe, necessary. They're two important sides of the same coin, right? So let's start with necessary. Was it necessary? Patient had a dilatation to 12, persistent dysphagia. When we came in, it was pretty narrow. What do you think about necessary? What do people think? Do you think it was necessary to go more?
I think you should go to what is possible in a safe way.
It brings us a question: what is your target in dilatation? Like, is your target 25 in the esophagus? Is your target 20? Is it 15? What is it?
Well, based on Peter Jan's presentation, we talk about refractory if we can't maintain above 14 for 4 weeks. So, yes, it is necessary.
Yeah, I think
that point,
I think the rule of thumb is you can either pass an endoscope, because normally to pass an endoscope you need quite a decent diameter. You probably need 14 or 15, or we get a dilation to 15. These are my rules which I'm following. Are they evidence-based? Maybe a little bit, but certainly they seem to work in practice. Which means that this patient has only ever got to 12. She's persistently, we've got refractory stenosis. If we can get it to 15 or 14, 15, then I think it's necessary.